Thank you so much for the presentation. So I am going, I think that, can you see my screen now?
Yes, we can. Thank you.
Thank you. So I'm going to present my project that is the feasibility and health economics of implementing evidence-based prevention interventions for smoking cessation in pregnant Aboriginal women into primary care services. So as Francesco was mentioning, he's my supervisor. I have great supervisors. I have Michelle Boville, Dr. Hannah Carter, and Professor Gillian Gold. They have different backgrounds in health economics, and also they have been working in Aboriginal settings previously. So before I start, I'm joining from Coffs Harbour, Australia. So I would like to acknowledge the traditional owners of the land where I live, the Gumbaynggirr people, and extend my respects to elders past, present, and emerging. And I would also like to extend this acknowledgement to the traditional custodians of the land where you reside. So an introduction, well, I'm going to talk a little bit about tobacco smoking and during tobacco smoking, and this is one of the highest preventable risk factor for global burden disease. And in terms of pregnant women, since compared with 2009, the smoking rates have decreased, but at the moment it still represents a problem. And during the pregnancy, it affects to the mother and the babies. And some of the effects that we have are stillbirth, respiratory disorders, low birth weight, and among others. And in terms of a specific population, Aboriginal pregnant women are 4 times more likely to smoke comparing to non-Aboriginal women. And according to the Australian Institute of Health and Welfare, the smoking rate in Aboriginal pregnant women was around 44%, compared with 11% for non-Aboriginal women. But in contrast, we have that Aboriginal women are willing to do the best for the babies, and smoking cessation programs during this period provide a window of opportunity to address these issues. In Australia, since 2010, we have different initiatives. We have the Tackling Indigenous Smoking program that was established in 2010, and it has an initiative that is called Closing the Gap that aims to improve the low birth weight of Aboriginal babies. And also it aims to decrease the differences in life expectancy between Aboriginal and non-Aboriginal population. One of the main targets is to address the low birth weight, but we also want to increase the proportion of healthy babies to 91% by 2031. And also, Australia is committed with the Sustainable Development Goals that have 2 aims related to smoking cessation in pregnancy. One, that is to prevent the deaths of newborn and children under 5 years of age. And the other one is to strengthen and enforce the implementation of the World Health Organization Framework Convention on Tobacco Control. And here in Australia, we have different interventions that are focused on smoking cessation. We have the Quit lines, and they have where they provide smoking cessation by phone counseling. And they have specific counselors that are also for Aboriginal people. We have a smoke check, and we also have Quit for New Life that are interventions that are focused on this population. Additionally, we have the pharmaceutical benefits scheme that provides nicotine replacement therapy for this group. In terms of cost, we know that the cost of smoking is, well, we know that smoking causes a big burden to the health system. In general, they said that the expenditure on tobacco per capita in average is $2.23 here in Australia, and the recommended expenditure should be $4 to $10. So that shows us that we have limited resources to address this, and we need to think about the impact of the programs, the cost of them, and also try to look for the effectiveness of the programs to try to implement them. So in that sense, it is important to address and evaluate the success or the failure of interventions. And this could be associated with different factors. And one of the factors that I'm looking for is the readiness to implement. So there have been different options of checklists and surveys, questionnaires to assess the readiness to implement. But the checklist to assess the organizational readiness for the evidence-informed practices has 8 domains that some of them are related with structural readiness and also include components of training. So this one is related to the intervention that we have. Also, there exists another instrument that I found that it was similar with the aims of our project, that is the NOMAD instrument that has been applied for the normalization of the complex healthcare interventions and to assist the development of and implementation of the process. Other frameworks that have been assessed the impact of different interventions one of them is the Vhep framework that assesses the impact for translation health research, and it covers different areas: the process of the implementation, the translation research outcomes, the impact and metrics. And we use different methods. We use the modified payback, we use economic analysis, and also we use narrative information to assess the impact. And this has been implemented with the different programs on non-communicable diseases here in Australia. So another framework that has been applied in research related to smoking cessation has been the framework, the behavior change of the will, that was assigned to evaluate the behavior change of the interventions in the healthcare area. And also it has been applied with the development of training for treatment management. In this sense, this framework covers different areas, but the main area that I am focused is the capability, opportunity, and motivation that makes the behavior change. And we will talk about that later on. So the aim of this study, of my PhD study, is to analyze the feasibility and the cost of implementing a smoking cessation intervention for pregnant Aboriginal women in Aboriginal and mainstream services. So I'm going to explain a little bit about the context of the studies. So in 2016, we have one first phase of this study, that it was the co-production and pre-testing of the material, that it was focused on training smoking cessation for specifically interventions focused on Aboriginal pregnant women. Then in between 2016 and 2017, we have I Can Quit, that it was a pilot study in 6 services that were trialing all this material that was produced. Then in 2017 to 2021, we have ISISTAQUIT that provide webinar training. It was a trial that compared webinar training versus usual care and obtained different metrics in terms of smoking cessation and also metrics related with the baby outcomes. And then we have in 2019, the 4th phase of the study, that it was the implementation of ISISTAQUIT, that is online self-paced training compared to the previous one that was a face-to-face one. And also includes a component that is related with electronic medical records. And from September of 2022 to 2023, we will have the Scale Up program that will be the national implementation of ISISTAQUIT. And my project is basically focused on the phase 4 but I have a component, one of my objectives that is going to be focusing the phase 3 and other ones that on the recommendations are going to be able to provide some feedback for the scale up for the phase 5. So in this ISISTAQUIT options, we have two types of arms. So we have a research component where we are going to be measuring different outcomes, and we have another one that it will be a training only area. The picture that we see here is part of the material of the webinar, the online training that we have. We provide the ABCD approach. That means ask, assess, cessation aids, and discuss the family and social and cultural context. And also we have all this material that we have in the middle. We have a treatment manual, we have a journey booklet for the patients. The intervention also provides nicotine replacement therapy, and the doctors will have a patient flip chart where they can show all the material to pregnant women. And also we will have a couple of posters to show what options they have, and to also show the impact of smoking during pregnancy. And additionally, as I mentioned before, we have electronic medical records. So on the system, on their electronic medical record system of the services that are part of this research package, they will have a prompt that helps them to, or guides them with this ABCD approach, and also gives them referral to quit lines and assist them with the care and treatment of pregnant women. So this is a general overview of my project. I am aiming to cover 5 studies that are going to show the feasibility and health economics of implementing ISISTAQUIT. Well, my first study is going to be a qualitative study. We are going to look for the lessons learned for SISTAQUIT, the SISTAQUIT trial. Then we will have a mixed method study. It will be a pilot assessment of the readiness to implement this smoking cessation intervention. The next part will be the impact of the smoking cessation interventions for Aboriginal and Torres Strait Island pregnant women, applying the Vhep tool. And then the next study will be a quantitative study that we are going to do a microcosting analysis of the ISISTAQUIT intervention. And the last study is going to assess the health providers' preferences for training. So with all these objectives, we are assessing the impact, well, all the process. We have one study that is going to show us the lessons learned. We have other studies that are showing us the readiness to implement. We also have the health economics component and the costing analysis of it. And the last study is going to show if all the training that we have providing, if there are some preferences of the health providers, and if we can adjust the training so everyone can do it. Here are all the objectives. So I have explained them before, but I just want to mention that the phase 3 was the SISTAQUIT trial. So from the trial, we're trying to look the challenges and enablers to try to include these lessons on the next phases. Phase 4, we're evaluating the readiness to implement, an impact assessment, and a microcosting analysis. And in the study 5, the phase 4 and 5, we're looking for the factors that influence the health providers' preferences for training in the smoking cessation care. So all these projects have already an ethics approval of 8 different committees that were in different, because we have studies and health services in different states, and also they are approved by the Aboriginal Health Research Committees. And we are including a component of, well, we take into account the data sovereignty of the Aboriginal Torres Strait Islander people. So we know all the health services are owner of their own data. They receive reports of all the information. The information will be provided in an aggregated way, and they identified. And we have different panels. We have on each of the phases, we have an Aboriginal advisor panel that help us with the design and implementation of the project to make it acceptable by the Aboriginal community. So this is a little bit of the explanation of the first study that I'm going to be conducting, that is exploring the implementation challenges and enablers of the trial. So we want to make recommendations for the next phases, and at this moment will be most of the recommendations will go for the scale up. Is a qualitative and retrospective study. We have 17 services that were invited to participate on the interviews that we're conducting. And we recommend to include between 1 and 3 health providers from each services. They could be CEOs, managers, research facilitators, doctors, midwives, or nurses. And the interviews were going to be conducted by an external Aboriginal agency. And we have, as you can see, the pink fuchsia points to show the location of the different services that we have for this trial. So we have health services in almost all the states. And up to date, what we have is that we obtained 19 interviews from 11 services. 3 of them were in Queensland, 5 of them were in Queensland, 3 in New South Wales, and 1 in Western Australia. They have been transcribed, and we are doing the analysis. We're using the NVivo software for the analysis, and for the coding, we have an Aboriginal researcher that is conducting the part of the coding, and I am the second coder. We're using the behavior change wheel framework, and specifically the COMBI model. So we're looking for the capabilities, opportunities, and motivations. And so far, we found that in terms of capabilities, we have time constraints of the health services. Some of them, we know that only specific doctors can provide nicotine replacement therapy and not midwives in all the states. So that is one of the limitations. Then in terms of the opportunities, we have the resources that the intervention has provided nicotine replacement therapy, has provided information for the pregnant woman that has been useful for them. And another barrier was the length of the surveys so far, because as this was a trial, we have different surveys that were applied for pregnant women, and also information that was collected about their babies. But on the other hand, we have some facilitators, like for example, iPads that were provided. And for the participation, a pregnant woman received a voucher in compensation for their time. So that was part. These rewards were, and these incentives have also helped to engage pregnant women. So in terms of the second paper, we have I'm trying to identify the health provider's readiness to implement the intervention. And that way we can try to see what kind of support we can provide. At the moment, we have recruited we have invited all the research training participants, health services, to be part of this. So we will have 3 different phases. In the first phase, we will implement the CARI checklist, the checklist to assess the readiness to implement. And it's going to show us if the service has all the required components for the intervention. Also, we are going to include interviews on this phase to have additional information, more in-depth information of them. The second phase will be collecting information for the participants, for the health providers that have received the training. And we're going to use the normalization measure for measure development questionnaire to see if they are ready to implement and if they think that the information that they have learned is feasible to apply, is relevant for their settings. And after that, we also are going to collect information from the medical records and training logs documents that we have. So with this, with all this information, we will perform triangulation of the data to see if the services are ready to implement and what are the challenges and what have been the main barriers for the implementation of the intervention, if there is some, or which facilitators they have too. These are some of the areas of the CARI and NOMAD survey. So in terms of the CARI survey, we measure system capacity, organizational capacity, functional considerations, the culture and climate, leadership, staff capacity, if they have an implementation plan. And also we have a component of training, that this is one of the main components that we are looking for. And apart from that, and something that the CARI doesn't include is part of the Aboriginal setting and also the interaction with other services. So in the interviews, I have included some components that are measuring that part. And in terms of the NOMAD survey, we are measuring health provider characteristics. We perform general questions of the information of the intervention, and such as if that's applicable for them, and other detailed questions that are going to be more focused on the implementation and what are their attitudes for implement the intervention. And for the analysis, in terms of the qualitative data, we will use NVivo similarly to the other study. And in terms of the on the general scores and the surveys, we will use descriptive statistics. And so far, as I mentioned, we have 4 organizations that have been recruited, and we have performed already 2 interviews for the first phase to the CEOs, and we are trying to recruit between 2 and 5 people per service. And one of the questions that I had before was about why we're looking for 2 to 5 people per service, is because some of the services, in average, the services have around 3 people that are going to be providing this care to pregnant Aboriginal women. So we're trying to target that group of population. And the next paper, the next study that I'm aiming to do with my PhD is to assess the impact of the ISISTAQUIT intervention using the Fate tool. And this is going to be a prospective study. We are going to include all the services that are participating on the research package, but also we're going to include some metrics of the training. We have, to obtain information, I have developed some administrative tools to collect information that is related with engagement with the services, time that they have, that we have spent with the recruitment. We have minutes about them, and also we have information about the electronic system that they have and the medical records too. So we're recruiting information from different sources. It's from the administrative sources to the training software that is HPMI, and also the medical records that they are using. And these are part of the information that we're going to, we will collect this part. We are going to include information related with knowledge, advancement, clinical implementation, if there are some community benefits. We have a social media campaign that is going to be included with this intervention. We will include information related with policy and legislation and the economic impact. And in terms of the economic assessment, we are going. I'm collecting information of the cost of the research program, and we are looking at different outputs that are related with number of pregnant women that quit smoking, and in some cases, it is possible to obtain information of the weight of the baby. That will be the long-term output that we're aiming to, but is going to, this outcome, we're not sure yet if this outcome is going to be feasible to collect, as the babies will have a different ID in the system. And also we're including narratives. We have a lot of community engagement, so we're including part of the community need. We have different research responses and outcomes, and including narratives related with the impact from different groups. And this information will be presented in a descriptive form. We will have the impact metrics, outputs, and also the process evaluation. And so far we have performed a workshop and look for the relevant information that will be collected and share that information with the team for their feedback. In terms of the team, apart from the core team of ISISTAQUIT, we also have the Aboriginal panel that provides us feedback, and the academic panel that includes provides feedback to the design of the research. And the fourth study is a microcosting analysis of the implementation process. So we are trying to obtain this microcosting analysis from the health provider's perspective. And we are going to have some mainstream services and Aboriginal services, and we will look if there are different variations of the costs depending on this variable, and also the staff composition. So we are recruiting the Aboriginal medical service and the mainstream services, and only the ones that are participating on the research package are we're going to be able to obtain this costing analysis. So that means that we will have only 4 health services with this analysis. So far we have on the training around 14 services that have been engaged, but it's just the training part. And this is going to be a prospective study, but we're going to include information of the design cost, the initiation, also the maintenance of the project too. And for the analysis, I will use data, and we will include all these costs: the startup, administrative services, training, and treatment costs. We will obtain the information that I will obtain will be from the different site logs and softwares that we have in each service. And so far, all the tools for the data collection have been already incorporated and for each stage of the research. And we are starting to collect the information now that we are starting the training with some of the services. And my last paper and objective is going to be focused on the health provider preferences for training. So we want, I want to identify if there are individual factors that influence their choices for the training. And we know that health providers have limited time, but we know that also they are motivated for training. The study design is going to be a mixed method study. The ethics is going to be submitted at the end of this month. And we will have 3 phases on this study. One will be a rapid review of the factors that are associated with successful training for health providers. The second one will be interviews to obtain the provider's preferences of training. And the third phase will be a health providers online survey. So for the rapid review, I aim to look for Medline, Embase, PubMed, and Google Scholar, and also include the snowball technique. We will look for studies published between 2011 and 2021. And in terms of the interviews, I aim to perform 15 semi-structured interviews to explore the preferences of the health providers. And in terms of the online survey, we will estimate the sample size for this survey. And this is part of the timeline of and the objectives that I'm aiming to have. So far we have a little bit of delay due to COVID, but in terms of the first objective, we have already we have collected all the information. We're coding now the interviews. The readiness to implement assessment has started, and once we finish the recruitment of the services, we are going to be able to perform the surveys. And for the impact assessment and the fate analysis, the information has been continuously obtained. And similarly, with the microcosting analysis and the discrete choice analysis, we aim to start in a couple months with the literature review. And that is all what I have for today. I don't know if you have any comments or questions.
Many thanks, Gina. Surely I invite everyone in the presentation to make their contributions or questions for us. I have while they think about it, and probably the best way they can ask you or us for more clarifications or comments or even suggestions is probably to utilize the a Q&A or chat boxes that you might find here in the Zoom environment. For me, Gina, while they think about that, I have one question. So obviously you're looking at a number of very interesting studies, and certainly you want to have more clarity on what the barriers are for professionals, and you've done quite a bit of work already on this. Can you be more specific and let us know what you've learned so far about these barriers and in the RCT environment that you have been working on, and in particular whether you think there are, or whether you think or whether you know there are striking differences with general population groups.
So yes, so far we have one of the main barriers was with the engagement of the services and trying to include all the ethics applications. So as you have seen, I have 8 ethics committees. So apart from the ones of the university, we need one of the state, and then we need an Aboriginal one. So that means a process that is time consuming. And sometimes when we try to plan the research, we don't take into account to apply to 3 different ethics committees. And as this research was going to be applied in a national way, we also we need to apply for each different state for ethics applications. So perhaps that was one of the barriers in terms of research. The other barriers in terms of research was with the trial, all the data that we need to collect. So if you perform surveys or questionnaires, that means that is one activity that is time consuming. Health providers don't have limited time. So these activities should have some type of remuneration, or we would need to try to include a way that doesn't alter the service delivery that they have, and we can collect easily the information using the softwares and the platforms that are already in their hospitals or in their health services. So I think that is a general, perhaps a general comment with all the research part. And I think that one other barrier is just the topic, because some of the health providers are worried about harming the relation when they talk about any smoking cessation or any drug consumption with Aboriginal pregnant women. So this has been a limitation, and that's why the training is addressing this and to provide cultural appropriate smoking cessation care for this population. But perhaps these are implicit and intrinsic barriers that would take some time to be able to have a change on the service. And also the guidelines. We have, in terms of nicotine replacement therapy, like 10 years ago, they recommended that this would be provided with advice of your health provider, but is not as part of the actions that should be given. So the way that they framed that on the guidelines was a little bit ambiguous. So that has made health providers to be a little bit more cautious on providing nicotine replacement therapy. We know that the evidence has shown so far that it's better to have nicotine replacement therapy than to have a pregnant woman smoking. But just having an ambiguous guideline that hasn't been updated has been a barrier in this type of study.
Yes, sorry for the cough. I didn't mean to interrupt. I thank you for the answer provided, and Chiaki Kojima, sorry for the pronunciation, asks an interesting set of questions. Is there any reason why NT, so the Northern Territory, I assume, is not included in your study? The state holds the biggest Aboriginal population. Was it difficult to obtain the response from the service providers in NT? Was it related to ethics committees' approvals?
So we have ethics approval for Northern Territory. One of the barriers was I think that with Northern Territory, one of the barriers was the engagement, the time of the engagement, and COVID. Because with other states, perhaps we start first with other states, and once we start with Northern Territory was the moment that they have more problems in terms of COVID. So that make it difficult to engage them, as that was not the priority. But we try to engage them, and the next barrier was the time, because we have in our timeline, we will need to finish the training by the end of May. So that means that we have only 1 month to provide the training. And even when we have their interests of different health services, they are going to participate only on the training research, on the training arm, sorry, and not on the research arm. So that is, well, in terms of research, that is sad, but it's good that we have different services for the ISISTAQUIT intervention. We have engaged different services that are in Northern Territory.
Excellent. Gina, one last question. So how is your thinking going when it comes to the survey-based component that tries to really understand better preferences or attitudes and so on? What is your thinking in terms of the actual methodology you're gonna use? And one aspect that and concern is not the right word, but makes me think a little bit is sample sizes. So what are your strategies or ideas?
So we want to apply this correct choice experiment for assessing the preferences of the health providers. In terms of sample size, this is, well, unfortunately, this is not going to be just focused on Aboriginal health providers, as we know that not only Aboriginal health providers are going to be attending or taking care of pregnant women. So we're trying to make it broader to be able to have a good sample size. And in terms of how we will do that, we will try to include different colleges, for example, area CGP, to send this invitation to participate on the survey, and also try to include other representative colleges for midwives and nurses and the target population that we have for the training.
All right, thank you, Gina. I think we can come to a close for today. If there are no other questions, I see that you have Chucky thanking you for your comprehensive response. Let me see, maybe in the chat. Jennifer also congratulates you for your work. And yeah, maybe I leave you, Gina, with a thought about considering to involve Indigenous communities overseas and connect with groups that do similar work to see what you can do with your survey-based tool, which I find with great potential in essence. So good work, Gina. Thank you so much for your presentation. Thanks for those who came to attend today. Stay tuned for the next PhD talks, and also our webinars coming up next. Final note from Stephanie, who thanks Gina as well for the great talk. Thank you, everybody. Bye-bye.
Thank you. Bye.